people from Estonia. Maybe, oh yes, I have the clicker to change slides here. We have Tiina Sats from Estonian Health Insurance Fund. Estonian Health Insurance Fund is the single payer of all healthcare costs in Estonia. Tiina has been the project lead in this project from the beginning. So great to have you here, Tiina. Also, we have Terje Peetso, medical doctor and member of the management board from the North Estonian Medical Center. North Estonian Medical Center was one of the hospitals that implemented the stroke standard set, and Terje is representing these implementers or the other hospitals here. My role and role of Nordic Healthcare Group in the project was to implement the data collection and the visualization of the outcomes. The agenda of today is that we will first go through the backgrounds of the pilot, so essentially from a patient, payer, and the provider perspective, that why this pilot was important. Then we will go through that how did we actually collect the outcomes and how did we visualize them. Then we will go through the results, both from the hospital perspective, but then also from the payer and the pilot perspective. And finally, we will go through that, okay, what were the lessons learned and what will we do next based on this pilot. But okay, let's go to the background of the pilot, and first we will have a little video of demonstrating the importance of this pilot from the patient perspective.
My husband had a stroke. It all happened so suddenly and changed everything. I had 1,000 questions on my mind. Why him? Will he recover? How do we go on? They took good care of my husband in the hospital, but when he was sent home, we were left alone with our worries. Nothing was the same anymore, but I didn't know who to ask or where to get help. I feared that I had to stay home with him and no one would help.
In Estonia, about 4,000 people have strokes every year. A stroke is a sudden and severe condition with serious and life-changing consequences for both the patients and their family. Approximately 20% of stroke patients die within a year after the stroke. 50% recover completely or sufficiently to cope with daily life. And 30% remain dependent on external care. In the stroke patient care pathway, a patient meets many parties, from the neurologist and rehabilitation specialists to primary care centres and social workers. Acute care provided immediately after the stroke is effective, but the subsequent care pathway is fragmented and complex from the patient's perspective. The process includes many parties, often with poor cooperation or coordination between them, which leaves the patient and their relatives confused and without necessary services. In 2019, the Estonian Health Insurance Fund started a stroke care pathway pilot project. The goal of the project is to improve stroke survivors' quality of life through more people-centered and integrated care. The project has 3 interlinked parts: care pathway development projects, measuring patient-reported outcomes, and a new payment model. The project includes 4 hospitals that in turn have engaged over 50 cooperation partners. The development projects test various innovative solutions on how to ensure the following outcomes. The patient and their relatives are provided with timely information they can understand and be involved as equal partners in decision-making. The parties to the care pathway agree on their roles, meaning who does what, where, and how to facilitate the patient's transfer from one stage of the pathway to another. The patient has a comprehensive care plan that is available to all parties and accompanies the patient along the entire care pathway. The patient and their relatives have a coordinator to turn to for help and who guides them through the different stages. The patient receives services close to their home or at home based on their individual needs and preferences. For the first time in Estonia, patient-reported outcomes will be systematically measured. This helps understand a person's recovery resulting from the care process and what can be done to improve their quality of life. The new bundled payment model means that instead of paying for individual services, a single price is agreed for the entire care pathway. The idea is to stimulate cooperation and coordination between the different service providers to ensure that every stroke patient receives the services they need. The new solutions are being piloted until 2023. If successful, they will be applied nationwide in the future.
Patients and their loved ones shouldn't desperately seek for help and worry so much alone. The Stroke Care Pathway Project seems to be exactly what could help people like us in the future.
Visit the Estonian Health Insurance Fund's website to find out more about the pilot, an integrated care pathway for better quality of life.
All right, that was the patient perspective. And Tiina, could you also tell a little bit about Estonian health insurance, the national payer perspective here?
Yes, thank you, Vesa. And first, I'm so thankful that I can be here today and share the experience of our small country with value-based healthcare. And before I reveal if the pilot was successful and if we will scale it nationwide, I will tell you how we started in the first place. So it was 2018, the Association of Neurologists turned to the Ministry of Social Affairs and to the Estonian Health Insurance Fund regarding problems in stroke care. So two main problems were raised. Firstly, all the patients were not transported to stroke units and centers where they had specialized stroke care. And the other problem was that there was insufficient amount of follow-up care, including rehabilitation. And as clearly the specialists saw the need for change, we decided to capture this momentum and start with our first national value-based healthcare pilot project. And at that time, value-based healthcare was a very new concept, so we didn't have any experience, we didn't have any knowledge, and this caused a certain level of fear in the system. So we decided that most of the aspects of the pilot will be coordinated by the Estonian Health Insurance Fund. For example, defining the pathway, what is the beginning, what is the end, defining the problems from the patient perspective, also agreeing what are the outcomes which should be measured during the pilot. We were also providing an IT system to collect the outcomes and also to benchmark the outcomes. And finally, we also developed a new payment method, bundle payment. And as we saw that the commitment and the ownership of the specialists and the hospitals is so critical, we decided that the most important aspect of the pilot, which is organizing the pathway, will be coordinated and implemented by the providers in the Estonian health system. But we didn't want to force the providers to join the pilot. So we decided to make a call for proposals. So all the providers who share our values, want to join the project, should come with their plans, how they want to organize the pathway. And looking back, I have to say it was a very good decision, because we went from force to this healthy peer pressure and competition. And in the end, all 6 stroke units and centers came with their plans, and we supported 4 of them with 1.5 million euros, which was also including the IT system. But Terje, I'm very interested to hear what is the hospital perspective and how did you get started?
Good afternoon, everybody. Yes, it was a challenge, I have to say. Even I'm happy to admit that, in fact, a lot of our doctors had an interest towards implementing the ICHOM standards and to look for introducing the patient reporting outcomes, we have struggled with establishing the platform, just because it was extremely expensive. So the fact that this was coming with the financial support and the platform was set up by the Health Insurance Fund was, of course, a positive thing. From another hand, the change is always good if somebody does it, but if you have to change yourself, that is not such an easy thing. So, in one hand, we very much relied on our principles of innovation, where you have to agree on who is in the team, what are the objectives, what is the timeline. If it's a pilot, it will end one day, which is a positive sign, of course. All these aspects to take into account, to also consider that it is an additional resource, so you have to have a better time planning, and we actually run it in COVID period. So it was a double challenge in that sense. But we also took into account what the other countries worldwide have demonstrated. What are the benefits for patients? What are the benefits for doctors? And everybody agreed to that. So, yeah, we were one of the 6 stroke centers that made the proposal, because one of the drivers also was the fact that if we don't test it ourselves, then we later will implement what others have come up with. So we thought that better to come on board. And we were lucky. We got into one of the 4 hospitals that were recruited to this pilot.
Well, thank you, Terry and Tiina. And I have to stress that I have heard so many times that it's impossible to do the implementation of outcomes measurement during the COVID time, but Tiina and Terry and the others in Estonia have shown that it is actually possible. So next, probably the question is that, so what is that you actually did? What outcomes you actually did measure, and how did you use those outcomes? So let's look into that. The basis for the outcomes measurement was the ICHOM standard for the stroke. And what was a little bit unordinary, that we've been involved in many ICHOM implementations, and typically you need to select some sub-part of the set that you are collecting. However, in Estonia, you actually did collect everything. All the case mix variables, all the clinical outcomes, all the prompts, the full set. And not only that, you also collected the cost measures, full care pathway cost from the acute care, rehabilitation, even readmissions. So pretty remarkable. And how that all was orchestrated, that there was 4 hospitals, as was mentioned, Terry representing one, that collected the outcomes and cost into Philips guest link, which is basically typically a prompts collection platform, but there we also included the clinical outcomes. The cost data came from Estonian Health Insurance Fund, being very lucky to have a unified data repository also already for the costs. And then we collected all of that into one unified dashboard for outcomes benchmarking. As probably most of you have looked at those ICHOM standards for outcomes, and there's really a lot of different KPIs. So those individual KPIs are super important when having the discussion between the physician and the patient, so that you are able to really dig down in the details of how the patient is feeling. However, in parallel, you should also have the summary view. The management and the sort of national payer needs an overall view of what are the outcomes in overall, what are the costs in overall, and how do those relate with each other. So we created a dashboard that does that, brings the outcomes and costs together, but it has the functionality where you can dig in deeper. You can go deeper in the outcomes, to the individual metrics, really detailed patient segments, and also the cost the same way that you are able to break it down to individual care pathway steps. But how that looks into reality? So this is the summary view. This is available for both the payer It's available for the hospital management, but also for the physicians. On the left-hand side, you first have quite detailed filtering functionalities. You can, for example, select specific time period, you can select specific patient segments, specific case mix variables, and really detail what you are looking at. Then on the top left corner, you have outcomes index. As mentioned, the outcome standards, there's a lot of KPIs, and in order to put that all together, we created together outcomes index that sums everything together into one number. Then on the top middle, you have the cost components broken down, average cost per patient broken down into the care pathway steps. And on the top right, then you have even the those costs and outcomes related between each other. Then even on the summary level, it's useful that you can dig down one layer deeper. And here we have this kind of deviation analysis. Here we have hospital D selected. Hospital D here, this is illustrative figures, not the real numbers, has the highest outcomes and actually the lowest costs. But by selecting the hospital D, then you can see in the deviation analysis there at the bottom that actually some parts of the outcomes are really a lot better than average, but you still have some dimensions that are lower than average. So you still have some room for improvement compared with other hospitals in some outcome areas. And the same goes with cost, that you, even though you are best in class in terms of the cost on average, there typically are some cost elements where you are lagging behind. For example, in this example, it's the avoidable complications where the cost is higher. So maybe there could be something that you could work on there. But the sort of point is to summarize that both the cost data and the outcomes data and bring that information available for all the key stakeholders in order to have continuous improvement and actually steer the system based on that information. So that's how the information was gathered, how it was visualized. Then let's look at the actual results. First, let's look at the results from the hospital perspective. And there we case mix adjusted the results, and these are actually really very late ones. So we got this a week or two ago. But we have two different types of hospitals. We have more a local hospital, A and B, which is sort of central hospital, that is typically doing only thrombolysis treatment. And then you have hospital C and D, which are more regional, larger hospitals that are doing both the thrombolysis and thrombectomy. So a little bit different treatment profiles, which makes it that you probably shouldn't be directly comparing hospital A to hospital C, for example. But interesting it is that when comparing these two central hospitals, there's one of the central hospitals that has clearly higher outcomes and at the same time also clearly lower cost. And as these are case mix adjusted, it is quite interesting and to dig down deeper. Is there maybe something that the hospital B could learn from the hospital A and implement those best practices also in their operations? The differences are smaller between the hospital C and D, but you still see that the hospital C has higher outcomes at the same time as having slightly bit also lower costs. So maybe again there could be something that hospital D could learn from the hospital C. And even though the treatment profile is different between the hospital A and hospital C and D, there probably could be something that larger regional hospitals could learn from this more local central hospital A. So quite interesting and something that we didn't quite expect, that there would be sort of significant differences between the hospitals based on this pilot. But next, Tiina, let's discuss how the pilot in Aura, what were the results from the pilot?
Yes. So the pilot had two aims: to test out the value-based healthcare concept and also to see if organizing the pathway, so-called development projects, do they result in a more integrated pathway, better quality of life, and also higher survival. Our intervention group, it was 260 patients. Our control group was 2,000 patients. And as we were using the ICHOM standard set fully, we could also compare those two groups by case mix. And we can say that the groups were very similar, with a slight difference in index treatment and also consciousness. And luckily, we can say that many of the results were also statistically significant. And I would say that the most important results was the 1-year mortality. So when we look at the unadjusted results, we see that in the control group, the mortality was 30%. In the intervention group, it was 16%. So if we do a very simple calculation, we can say that if we would scale this project in those 4 hospitals, we could save approximately 200 lives per year. So it's a big number. And when we look at the case mix adjusted results, they were also similar when it comes to survival. But there was a very unexpected effect of the lower mortality. And this was a lower quality of life as well in the intervention group. At first, we were quite shocked of the result, but then we understood that in the intervention group, the more severe patients survived, so also the quality of life was just slightly lower in the intervention group. So I think that this example shows clearly that we have to have a comprehensive outcome set. We can't focus only on one outcome. We have to see all the outcomes, which are important. And we also saw a good result in integration of the pathway. So we knew that the specialists were concerned about the follow-up care. And when we look at the rehabilitation, inpatient rehabilitation during 6 months after the stroke, we see that in the control group, the use of rehabilitation was 29%, and in the intervention group, 44%, much more. And we saw the similar trend also in outpatient rehabilitation and also secondary prevention visits. So we can say that the pilot was successful. We should think about scaling it nationwide. But of course, there were many lessons learned also for the scaling and the next projects, and maybe we will go to the lessons learned. So first example is that all the hospitals were testing out slightly different interventions, which was very good to get the commitment, to get the ownership, and also get more ideas. But now, after the pilot, all the pilot sites say that we need a national stroke pathway standard. How the patient moves on the pathway and what are the responsibilities of different parties on this pathway. And I know that, Terje, you have also many thoughts about this issue.
Yeah, I specifically asked to add this second part of it, because it may sound like if you set up a standard that everybody has to be treated by the standard, by the book. But the idea of the pilot itself was to allow the flexibility so that you can choose in the patient pathway the interventions that would fit for the purpose and that are welcomed by the patient and agreed with the patient, and objectives are agreed. So that I believe that if this standard will be set, this allows the flexibility. It's like a composition of all tools that you have in hand that you can use, but nevertheless it allows you the selection according to the patient needs.
Yes, I
So it's kind of personalized medicine approach.
Yes, yes. It's not that all the patients will get exactly the same treatment.
Yes.
Exactly. Yeah, and when we talk about the outcome measurement, there we even had 3 lessons, main lessons learned. The first was that we had double entry of case mix data. So the doctors, nurses were entering the data to the electronic medical records and also to the outcome measurement tool. So a lot of waste of resources, and we see that in the future we have to have integration with the electronic medical records and also with the claim systems. And this is, I would say, quite the easy win to not to waste so much resources. The other part was that we were very, very proud because our patients' response rate after 1 month and after 1 year after stroke was very high. On 3 months it was 85%, but it came with a price. So 80% of the data was collected by phone, and the ones who were calling were coordinators and stroke nurses. Again, a lot of waste of resources, and we see that this collecting the outcome should be more integrated to the normal daily work. For example, when the patient comes to the 3 months stroke nurse visit, maybe in the registration they will give a tablet and the patient will fill out the questionnaire there, and when he or she goes to see the stroke nurse, then the stroke nurse can already see the results and have a discussion about it. And the third point about outcome measurement is that the data was used to evaluate the pilot, but it wasn't used in daily work with the patients, and it wasn't used in this ongoing development process. We have already had quite good discussions how we should do it in the future, but there is a lot of work to be done. For example, the nurse will use the results of the questionnaires when having this 3 months visit, or maybe hospitals come together once a year or more to discuss, okay, we see here the differences. What is behind those differences? Maybe we can learn from each other. But again, Derja, I know you have thoughts about that.
I think that this data is much broader question here. It's not only whether it's collected by phone or by the iPad in the waiting room. It does not necessarily even have to be the stroke nurse. I think that this overall patient pathway, that's maybe is, if we think of the approach that we provide a service close to home, then it could be the GP nurse who is doing the same job. So it doesn't necessarily be in the hospital, wherever it is. But the importance is really the use of this data. And the data you mean here is the patient-reported outcome. So that this information is not only available for analyzing the results, but it's also giving an input to the neurologist who will perhaps the follow-up visit, stroke nurse, but it's also important in all other aspects, because it's a lot of questions about the quality of life that is important for a general practitioner or any other specialist who is using it. So that's why the last point, which is about an access to data, I think that is something what we, one of the interventions actually that we tried in our hospital was about how to provide an access to data, how to share information, so that all parties who are involved in this process, whether it's the doctor in the hospital, is it the nurse, is it the physiotherapist, is it the social worker, will all be in the same information space and have an importance of this information available, but can also make their own input, and this information will not get lost in between. So the tool actually that we used was not meant for health information. However, it was demonstrating the importance of this type of simplicity and access at any time, with, of course, under all granted of this identification and the data protection and security. But information of that data making available at any stage where needed is really crucial. That is something that we were able to demonstrate. We knew it before, but we demonstrated it again.
Yeah, I can't wait to have the discussions after this session. But also one lesson learned about the bundled payment. So I would say that technically it worked very well. We got used to seeing all the pathway costs all together. This was something new for us. But in the future, we also have to take into account the outcomes in the bundled payment to give even more the incentive to use this data with the work with the patient in the ongoing development process. But this was the story about stroke. But let's also talk a little bit what is the way forward, and what is the more wider picture. So from the Estonian Health Insurance Fund side, I will say that we will continue with similar projects with the aim to scale them if they are successful, so it will become a routine practice. And in the end of this year, we also are starting a pilot in joint replacement, and we are also taking into account those lessons learned from the stroke project. But we also want to give the opportunity to other stakeholders in the system to start with that kind of new projects. And since few years, we have an innovation fund in place. So this fund is used to finance central IT developments, but also new projects. And those new projects can be coordinated by Estonian Health Insurance Fund, but also by the providers. The budget of this innovation fund is, for next year, it's 10 million euros. And the last thing I would want to point out, as outcome measurement is such a critical part of value-based healthcare, then at the moment we are having discussions, should the Estonian Health Insurance Fund provide measurement and visualization tool for all the providers who want to measure the outcomes. So maybe in few months, 1 year, we can already report what was the conclusion of this. And of course, I have to stress that it's the collaboration with the providers is so important when doing those projects, and I'm very grateful to have partners like this, and especially to you, Terje. And I know that you also have many plans in your hospital, how you see the future.
Yeah, well, the stroke patient was not the first patient pathway that we started to use, because for oncological patients, we already had that for 2 years running at that moment. But we extended this knowledge that we gained through the stroke patient pilot also to our oncological patients pathway, in particular as regards the use of patient reporting outcomes, and also introducing the interactive tool for engaging patients even more. So the list here is all the pathways that we are currently in our hospital either preparing or already running, and certainly what we are looking forward is this platform that you are going to provide, because that is something that we need the support for.
Excellent. And I think here there's something into that by combining the sort of centrally, then on the national level coordination and the local level implementation, that I think everyone in the other countries we can learn from, and I think this is a great example. We have a little bit of time if there are questions or comments from the audience.
Thank you very much. I have a question about your outcome index, and I think I heard that from the ICHOM stroke set, you kind of condensed the scores or scales down into that simple number that was on that graph where you had A, B, C, and D. And I was curious about, is that something that's in the outcome set? I haven't seen that portrayal, or is that something that you developed locally? Will you be taking it further into your next projects?
Yes, happy for the question. Unfortunately, it's not readily available in the outcome sets, could be in the future. But because we saw the need for having the summarized view, we basically developed that in this pilot. And we will be developing those also in the future. That was the follow-up question.
All right, thank you very much. That was wonderful. I wanted to ask about patient-reported experiential measures. We know that the ICHOM set has pros in it, but being able to capture experience of the patient through the pathway, is that something that was a part of your pilot, or are these things that you're looking to implement in the future?
In this pilot project, as there was so much newness in this project, we from the Estonian Health Insurance Fund decided to collect only PROMs. But the interesting thing was that when the 4 hospitals came with their plans, all the hospitals said that we will also collect PREMs, which was perfect. But the thing which wasn't so perfect was that all 4 hospitals collected a little bit different PREMs and a little bit in a different way, so they are not so comparable. But definitely the good thing is that we have the experience of that.
Well, I would add here that in principle, we have the legal obligation to collect the PREMs for 6 hospitals in Estonia to compare. We did slightly modified version for this because we all had different interventions, and we tried to got patient feedback about how they feel in this pilot and these specific interventions. But that also gave a good input because we just adjusted our PREMS model and introduced the web-based questionnaire that we will send to all our patients. We tested the first one on our outpatients, and that we got an input also from that in order to be up to date and to really get information which will be useful. It just doesn't make sense to collect that information that you would have some statistics, but in the end of the day, you will just know that yes, last year 96% liked your service and this year 96.5. So that is not very helpful. But the questions, if they would come with the some kind of indicators that you would like to improve, or what was most difficult, of course, that if you ask for free text, then you will get free text and you have to work on that. But when we spoke to our clinicians, they all said, please don't take away this part of free text because that is where we really get the good feedback and suggestions and comments. So I think that yes, it was different because it was for the pilot, but it gave a good input for the rest of the work that we do in the hospital.
Great. Thank you for the great questions. Unfortunately, we are running out of time now, but there's our contact details. If you have any further questions, we are more than happy to continue the discussion later on.
Wonderful. Thank you all so much. Please join me in thanking this fantastic panel.